Hello everyone, in this video we will discuss hereditary spherocytosis. So welcome on the video. So what is the pathology and genetics behind the hereditary spherocytosis? The most common inheritance followed in hereditary spherocytosis is autosomal dominant, and some of the cases are showing autosomal recessive inheritance. Primary defect is in the vertical membrane proteins of the RBC membrane, and the most common protein deficiency is Ankyrin. Other defected proteins are band 3, beta spectrin, and protein 4.2. So this is the diagram of RBC membrane structure, in which there are certain proteins like spectrin, these two band of spectrin, alpha and beta. This is Ankyrin, and this is protein 4.2, and this is the band 3 protein. So these proteins are essential for the membrane stability or structural stability to the RBC membrane. Whenever there is deficiency of any of these proteins, this will result into the increased RBC membrane instability and result into loss of the RBC membrane as the cell ages. So ultimately cell assume a size of a spherocyte which is geometrically efficient for volume to surface ratio. So cell become spherocytes from the biconcave cell due to loss of the RBC membrane. These spherocytes are inflexible and usually trapped into the narrow cords of splenic sinusoids. These trapped RBCs then phagocytose by the splenic macrophages and result into extravascular hemolysis. So what are the clinical signs, symptoms and findings are seen in hereditary spherocytes? A triad of anemia, as this is a hemolytic anemia, and due to hemolysis there is jaundice, and splenomegaly, as we have discussed, RBC trapped into the spleen and phagocytosed by the splenic macrophages. Splenomegaly is more consistent and prominent in hereditary spherocytosis than almost any other hemolytic anemia. So splenomegaly is very consistent finding in hereditary spherocytosis. As we have discussed, this is a case of hemolytic anemia. Due to hemolysis there is increase in bilirubin, and ultimately this will form gallstone, pigment gallstone, calcium bilirubinate stones, around 50% of the patients. Aplastic crisis can also seen in hereditary spherocytosis when the infection of parvovirus V19 is there, and this is identified by the drop in the reticulocyte count. Megaloblastic crisis can also seen, as we have discussed. There is increased hemolysis which promote the bone marrow to form new erythrocytes. So there is erythroid hyperplasia, and high cell turnover may result into folate deficiency and megaloblastic condition. To diagnose this condition, on peripheral smear there are spherocytes, small hyperchromic RBCs like central pallor. As we can see, these are the spherocytes, no central pallor, and usually small in this size of, or smaller in size than normal RBC. There are JollyBodies. They seen only after post splenectomy, as normally these pluck out or destroyed by the splenic macrophages, but after post splenectomy JollyBody can be seen. Hubble JollyBodies are the dark nuclear remnants or DNA remnants seen in the cases of post-splenectomy patient, severe hemolytic anemia, megaloblastic anemia. MCHC is characteristically increased in the hereditary spherocytosis due to relative cellular dehydration. MCV can be normal or low. Red cell distribution width is increased. Confirmatory test for hereditary spherocytosis is EMA binding test, eosin 5 millimide binding test. This is the gold standard test, which is flow cytometry based for hereditary spherocytosis. Osmotic fragility is increased in hereditary spherocytes as the spherocytes are less flexible and lies at the higher saline concentration. Direct Coombs test is negative, and this is very crucial to differentiate hereditary spherocytosis from the autoimmune hemolytic anemia. Now on the treatment part of hereditary spherocytosis, treatment of choice is splenectomy, usually deferred until after the age of 6 years to reduce the chances of sepsis. Preoperative vaccination against the encapsulated organism like Streptococcus pneumoniae, H. influenzae and Neisseria meningitidis is advised. Post-splenectomy smear shows Hubble JollyBody as we have discussed and target cells. Folic acid supplementation to combat megaloblastic anemia. So this is all about the hereditary spherocytosis. The important thing is the defect in the RBC membrane is skeletal proteins like Ankyrin, band 3, Spectrin and protein 4.2. So ultimately result into the RBC membrane instability. As cell ages, the RBC membrane loss and assume the size of spherocyte, which is geometrically efficient for volume to surface ratio. Thank you.